Hello and welcome. Thank you again for joining me for another one of our provider-only webinars. Today, we're going to be discussing a newer drug to our pharmacy, Nitazoxanide, of course, which is the reason why you showed up. So thank you so much for being here. I appreciate you being here live and spending some time with me today. I'm going to go ahead and, of course, share my screen here. As always, I have some slides that I want to share with you. And what we're going to do is we're going to start with a bit of a background on what nitazoxanide is. Of course, give a brief introduction to the pharmacy, as I always do, and then really get into the details about what this drug is and who it is used for. So, if we have not had the opportunity of meeting yet, or you're not yet a prescriber with our pharmacy, welcome. My name is Brianna Gregory. I am one of the pharmacists at Physicians Preference Pharmacy, and my primary role is actually the physician liaison. So, throughout the United States, I do facilitate the relationships between our prescribers and our one location of pharmacy at Physicians Preference Pharmacy in Houston, Texas. So, again, welcome. We're going to talk about some alternative applications of compounded nitazoxanide, and we're going to go ahead and just jump right in. So I always like to start with a bit of a background of who we are at Physicians Preference Pharmacy. It's very important to us that the quality and the potency of our compounded medications is really what we stand on. It's important to us that we not only vet the manufacturers and vet the suppliers that get our raw ingredients to us for compounding, but that we are always constantly vetting our employees and making sure that we're abiding by the SOPs that we've put in place for our employees. We also implement on-site testing and third-party verification as well. So that is what allows us to hold our PCAB accreditation. But again, if you've not prescribed with us before, we are a compounding only pharmacy. So 99.9% of what we dispense is made in one of our two laboratories. We do carry just a couple injectables because we do not compound those. We are a non-sterile compounding facility only, which simply means that we don't make injectables, we don't make IVs, and we don't make ophthalmics. So really, since our inception, we have primarily focused on compounding BHRT. So hormones are our bread and butter for sure, but we have expanded over the past decades into more immune modulating and immune supportive products for patients. Obviously, the terrain and the demographic has changed since the pandemic, and we have absorbed a lot of different types of patients since then. So we've been able to be on the journey with many more sensitive individuals, patients with cancer. And so our demographic looks a lot different than it did before, as I'm sure yours does in your office. Now, each of our preparations that are made and dispensed at Physicians Preference Pharmacy are going to be free of any unnecessary binders, fillers, artificial sweeteners, lactose, parabens, which are hormone disruptors. And even though that seems pretty intuitive, if you take a survey or an evaluation of other compounding pharmacies, you'll find that sometimes they are using these less expensive or cheaper ingredients, which might not be harmful to some folks, but many people do not tolerate these inactive ingredients. And additionally, those inactive ingredients oftentimes don't serve them. Dosage forms that we compound, as I mentioned, we're non-sterile. So we really focus on the non-sterile dosage forms, which would include oral capsules, oral suspensions, sublingual tablets are one of our most pharmaceutically elegant preparations that we have. A lot of our hormones go into our sublingual tablet preparations. Also, our peptides go into our sublingual tablet preparations, and many more. Also, of course, we do topical and vaginal creams. Usually that is as a carrier for hormones, and then nasal sprays. So we have some nasal sprays that address mold toxicity or mycotoxins, also peptides, think oxytocin, things that we want to be delivered to the nasal cavity, either to dwell locally or to cross the blood-brain barrier. Now, as I mentioned, I do serve as the physician liaison for all of our physicians that prescribe with physician's preference, and that spans across all 50 states. We do carry 49 state licensures, which means that we have patients in all 50 states, but we can only ship directly into 49 states. So for us to be able to do that, we can't just pay the state boards of pharmacy and they give us a license. Some of those state boards allow us to complete an application and go through an inspection and a survey to be sure that we are complying with their state board regulations. But additionally, there's about 20 states that require at least one of our pharmacists to sit for multiple state licensures. So we have several pharmacists on staff that are licensed in multiple states as well. Now, all of our prescriptions that are dispensed from physician's preference have to be patient specific. So we are a 503A pharmacy, and I want to make this very clear on the front end because I spent a lot of my time answering this question is, can you bill and ship to the office? No. We're a 503A pharmacy. That's not legal. We are very aware that there are a lot of pharmacies doing that. If you're a 503B pharmacy, that's a different story. However, for 503A pharmacies, you do need to write a patient specific prescription, send it to the pharmacy, just like you would back in the olden days. Patient calls the pharmacy, patient comes to the pharmacy, they pick up their prescription, they pay for it on their own, and they take it home. Now, at physician's preference, we generally are working with physicians who are more of the integrative or functional mindset. For that reason, we're usually working with patients that are also cash pay like we are, so we do not accept insurance. And additionally, we may believe a little bit differently than conventional medicine, where we need to be seeking out the root cause rather than just putting a band aid on the issue. That doesn't really help anyone except for to quote unquote stop the bleeding temporarily. So we are trying to figure out how do we partner with physicians? How do we partner with patients to address the root cause of symptoms? And not only that, but also help these patients optimize and live their very best so that they're thriving and not just surviving. As mentioned, we do carry PCAP accreditation. So if you're not familiar with that, it is a voluntary accreditation that pharmacies can seek out. It stands for the Pharmacy Compounding Accreditation Board, which means that if you go to a standard compounding pharmacy that's not PCAP accredited, they legally can dispense a prescription that is compounded and falls within plus or minus 10% of the intended potency or the strength that you wrote that drug for, that prescription for. With PCAB accreditation, it's tighter than that. So we have stricter standards, but additionally, we actually hold ourselves to higher standard than PCAB. So when we do on-site testing and third-party verification, we usually fall within 1% plus or minus 1% of what we tell you that we are making. So we like to keep that very tight. All right, so let's go ahead and jump into the drug of interest today. So over the past couple years, we have brought on several prescriptions that are just really funny to pronounce. It's kind of funny to hear prescribers call them in, and when we start making it for the first time, the staff try to pronounce it and giving presentations try to pronounce it. So it's kind of turned into a running joke around the pharmacy. But this would include mebendazole, ambexanox, rapamycin, which is sirolimus, and now nitazoxanide. So it's not nitazoxanide, it's nitazoxanide. Okay, so let's go ahead and start out with the history. We want to understand, of course, where did it come from? That really helps to give us some insight and highlight where we've been, where we are now, and where we're going with this drug, because nitazoxanide would fall into probably the repurposed drug category. Repurposed drugs are drugs that, just like it sounds, were developed for one reason, and then they found for one reason or another that either a side effect or an added benefit of a patient taking this drug elicited some effect, and that effect actually ended up being a benefit that that drug could be repurposed. The drug isn't changing, but the indication or the use is just morphing into something else, or I guess you could say it's more of a broad application of use. But that might be different than what it was originally FDA approved for. So I do apologize in advance if you're eating dinner while you're watching this. There are going to be a few graphic images. I tried not to pick too bad of ones, but in the 1970s, we see here that nitazoxanide was developed originally as an oral antiparasitic studied for protozoal and anti-helminthic activity. So it was actually initially developed to be used in veterinary medicine. And then in the 80s, efficacy was discovered against tapeworms in humans. In the 90s, we found the efficacy of antiviral activity, which is really where we come full circle around some of the benefits and uses of nitazoxanide presently. And then in 2002, nitazoxanide gained FDA approval of the brand name Alinea, and that might be the name that you're more familiar with hearing. or hearing from patients. So that is an indication, FDA approval, indication for the treatment of diarrhea caused by Giardia or Cryptosporidium in anyone older than 1 year of age. So that goes for children over 1 year, and then, of course, adults. Many of these repurposed drugs will be dosed based on weight. Nitazoxanide is based on age. All right, so we talked about the brand name, which is Alinea. Nitazoxanide, of course, is the generic. Now, I actually really wasn't able to find direct information about the availability of Alinea suspension. Again, we're a compounding pharmacy. We don't order commercially available products, so I'm not in that catalog day in and day out. Of course, I'm not a prescriber writing for this, but my understanding is that it's highly limited, the availability, or it may just be trending towards unavailability. It sounds like it's been on back order for a significant amount of time. So whereas that oral suspension may have allowed for some dose titration and flexibility, now the Alinea tablets are the only product that are commercially available, or the nitazoxanide. So again, it gained its FDA approval in the early 2000s for the Giardia and Cryptosporidium. Now, the drug class on this is really important, and as a pharmacist, this is where I get always really interested about how these drugs were developed. Of course, the chemical structure and backbone gives us information about what the drug does, its mechanism of action, but also it gives us some insight into other things that we can use it for. So it's a thiazolide, antimicrobial, but also an antiprotozoal. So that thiazolide backbone is what gives it its activity. Now, nitazoxanide itself is actually a prodrug. If you're not familiar with the term prodrug is like a precursor to the active drug. So we have some opiates that are like this, other drugs that are like this, but nitazoxanide is a prodrug that when the patient takes nitazoxanide, it gets metabolized by the liver and then converted into the active circulating metabolite. And the metabolite is what's doing the work, and that's tizoxanide. So we go from nitazoxanide to tizoxanide, and you can see that here. Actually, initially, this backbone is very similar to the chemical structure of niclosamide. So you can see how we're coming full circle with some of the other repurposed drugs as well. Now, the half-life of nitazoxanide is somewhere between 1.6 hours. It's usually thought to live around 1.3 hours. The primary mechanism of nitazoxanide, so the primary mechanism of action is actually really what connects the dots between the broad range of uses. So I'll refer to this a few times throughout this presentation, but primarily it inhibits pyruvate, ferredoxin, oxidoreductase, so P4 basically is what we abbreviate it as. And that's an enzyme dependent electron transfer reaction. So, a long way of just saying it's really essential for anaerobic energy metabolism. So, for bacteria and for parasites specifically, when this P4 gets inhibited, which is what nitazoxanide does, then it disrupts the typical normal anaerobic metabolism of bacteria and parasites. And that's what we're after. We're after the protozoa, we're after the bacteria, we're after the viruses, we're after the parasites. And a lot of these share those similarities in the way that they function. So again, with a lot of these repurposed drugs, we're not necessarily going after the primary offender itself. We think about this a lot in cancer too, when we use these drugs to support cancer patients. We're not killing off the tumor. We are addressing the pathways that feed the tumor. And that's very similar to how nitazoxanide works, is it's working on the systems within the body, not directly on the bacteria or the virus or the parasite. So again, it's repurposed for broad antimicrobial and antiviral properties. Here you can see we have a really broad spectrum of nitazoxanide. And I always love initially building out these PowerPoints because this is how I learn. I learn by studying, I learn by researching, and then I can competently put these together for you all and understand more about where the drug has come from and everything that we can really use it for. And as I was preparing initially putting this information together, I learned so much about the broad spectrum of nitazoxanide, not just for treatment of diarrhea, of course, but because it works in the gut as well and more systemically, it addresses things not just in the gut, but systemically. So it actually works as an antiprotozoal against, we already knew Giardia, and Entamoeba histolytica as well, which was interesting to me. Also works as an anti-helminthic, so that's against the worms, of course. And then as an antibacterial or antimicrobial, it's not an antibiotic. Interestingly, C. diff. So because of that genus that C. diff lives in, we do know that nitazoxanide or tizoxanide is active against C. diff. What about H. pylori? Also very interesting because if you've ever had H. pylori, which I have, you know that it just absolutely wreaks havoc on your gut and it can wreak havoc on your lungs and many other systems in the body too, especially if it goes undetected and untreated for quite some time. Additionally, the treatments for H. pylori can be fairly harsh, and our typical patients are usually looking for a non-antibiotic option, or they're looking for something else to complement it, or go more of an herbal route, something like that. But the other thing about H. pylori is it's exceptionally smart. It's a very smart bacteria that knows how to bury itself in the tissues and make itself undetectable for very long periods of time, as it does have a response to stomach acid and can hide from that and adapt to its environment. So the fact that we have another option for H. pylori is very intriguing to me. Also, nitazoxanide does have antiviral activity. And so, even though, well, especially in Texas, we didn't really have a winter, but we're still technically in viral season. Flu is going around rampant, especially even in kiddos right now. It seems to be hitting people harder, and I understand the numbers are higher this year. So, nitazoxanide does work against flu A and B, RSV, coronavirus, rotavirus, norovirus, and Hep B and C as well. So we do know that nitazoxanide carries an expanded mechanistic profile, meaning that its MOAs, it does a lot of different things. Now we know that there's a possible impact on both endosomal and non-endosomal COVID-19 cell fusion and entry. We learned a lot about the ACE2 receptors during the pandemic. We've learned a lot as this virus morphs and we get new variants of how and where the virus binds, a lot about the interaction of the spike protein with its environment, how that impacts tissues negatively and really sets up shop in the body and doesn't leave for years, if not actively removed. But also, the COVID-19 virus has different ways of entering the cell, and part of that is through endosomal or non endosomal cell fusion. So, how is it actually getting in the cell? Additionally, nitazoxanide inhibits several interleukins, also TNF alpha, and blocks viral protein maturation. So that's really important in not allowing the virus to continue its work. Also, nitazoxanide carries a low potential of developing resistance. So, drug resistance is a really big thing, especially in your treatment refractory folks, which pretty much all the indications I'm going to talk about tonight can carry a lot of treatment refractory patients. We see that pretty often with the indications I'll discuss. But and the reason why this is because a nitazoxanide has a host targeted mechanism. So as I mentioned, we're not directly going after the virus or the bacteria or the parasite. We're going after the system that feeds it or the maturation or the metabolic processes that allow that offender to live inside the host. We find that to be very effective, which also decreases the risk for drug resistance. Also, it does upregulate protein kinase R, which is relevant in hepatitis C. So let's start out by flu. We're going to talk about three separate indications here, and I will start with influenza. So nitazoxanide is a repurposed drug for the use in influenza. I already mentioned A and B. It does modulate the host immune response. So it does this by upregulating type 1 interferons, and that's important in the antiviral signaling within the host cell. So we're working with inside the host cell at an antiviral level. Again, we're working on the system. It's that host targeted mechanism. So unlike something like oseltamivir, Tamiflu, which inhibits the neuraminidase enzyme, so that's its mechanism of action to prevent virus release. The thiazolides, like nitazoxanide, prevent the virus from ever being properly assembled. So it's not equipped to do the same kind of damage because it was never properly assembled or doesn't exit the host cell by interfering with the hemagglutinin maturation process. The hemagglutinin maturation process is really important for how this drug works on the flu virus and not allowing it to progress towards infection. So it is also active, we see, against oseltamivir resistant strains. We've seen that in vitro. It does disrupt intracellular processing of viral proteins. Again, it's putting a monkey wrench in the system. So that equates to non-infectious viral particles. It acts early in the viral replication cycle, so it can reduce the total viral load, especially when given early in infection. So we do have patients that keep repurposed drugs like ivermectin or even hydroxychloroquine or methylene blue on hand because, of course, you never get sick at 9 a.m. on a Tuesday. You get sick at 5 p.m. on a Saturday when the pharmacy's closed. So you want to be sure that these patients have it on hand. So a key point here is that viral assembly and host response pathways are targeted. Again, they are targeted towards the host on the system, not necessarily the offending agent. So rather than the virus itself, it's therefore less prone to resistance, as we talked about on the previous slide. So what about COVID? So we've had a lot of patients that have said that this has helped to really intercept both in flu and COVID early on, that usually are bedridden or laid up for several days following infection, and they've done much better with the nitazoxanide. Now, nitazoxanide is repurposed, but also we see continued interest in the SARS-CoV-2 infection. Now, we know that it was active against original coronaviruses, also proves the same in SARS-CoV-2. Again, it interferes with the post-translational maturation of the spike protein. Now, my personal opinion, perhaps unpopular, is that the spike protein deserves a whole heck of a lot more attention that it's getting in our field. And I am definitely for testing this total spike load, and I'll unpack that more in a moment. But the reason why is that we continue to see the ongoing research since initial infection with the SARS-CoV-2 virus that spike protein lingers not just weeks or months, but years. And I, like never before, have seen more issues with infertility, more issues with weight gain, more issues with hair loss, more issues with brain fog that they almost seem unexplainable by the patient. And I have talked to a lot of doctors that are not testing for this, and they're not even asking the patient about their COVID history. What was your experience when you were infected with COVID? Were you vaccinated with the COVID vaccine or boosters? If so, how many did you get? What was your response to that? Did you respond differently after you received those vaccinations? Whether or not a patient is vaccinated or had natural immunity, they're going to be carrying around some version of a spike protein load. And so, by getting a good idea of this, we can understand if this is one of the root cause issues of perpetual inflammation, repeated infection, and a weakened immune system. So, nitazoxanide interferes with the post translational maturation of the spike protein, which again, that's required to bind to the ACE2 receptors. Those are in the lungs. That is similar to the action that we just talked about in influenza, the influenza hemagglutinin, exactly. So the host immune response, keep emphasizing that nitazoxanide promotes activation of antiviral genes. So it actually works at a genetic level too, in interferon stimulating genes, which play a role in defending against viruses, against pathogens. It upregulates that same type 1 interferon, which is important for antiviral signaling within the host cells. So nitazoxanide can actually reverse early interferon suppression by the SARS-CoV-2 virus, preserving the immune response. Again, we're trying to stop people from getting knocked down so far and their cells getting completely hijacked with viral infection, especially because of the impact of the spike protein and how it just sets up shop and it doesn't want to get out of the body. It's very smart protein. Also, nitazoxanide is suggested in vitro inhibition of SARS-CoV-2 replication, inhibits pro-inflammatory cytokines like we see with a lot of the repurposed drugs that we use in patients that have COVID. And it does have a bronchodilatory effect. So it is going to work in the lungs to open those airways as well. Now, just a moment to take on the spike protein test. So, spike load, when we think of viral load, we can also measure the total spike protein antibody load in the blood. So, in that certain amount of blood's taken, we look at how much spike protein is in it. And I do get a lot of questions from prescribers and from patients about this. Actually, this is a question I always ask patients when they kind of have these very stubborn, unexplainable symptoms that have especially come up post COVID and just were not congruent with symptoms that they were having before. Something's changed. So, why wouldn't we go after what has changed and start there? Now, there are different spike protein related blood tests that are available. Most of these do require a doctor's order. LabCorp has recently opened it up for patients to order the spike protein test directly. We do not need to see evidence of past infection. Who cares? Everybody has been exposed to COVID. There's absolutely zero value, in my opinion, for doing a test and saying, look, you've been exposed to COVID. Okay, yeah, we knew that. What we're looking for is the total spike load. So we're trying to see what that number is. According to labs, that number should be less than zero point 0.8. Many patients that have these stubborn symptoms are popping at 10 or 20,000. So 0.8 to 10 or 20,000. These people need help. Help them get the spike protein out. Now, this is not a presentation about how to get the spike protein out, but over several years of talking to my patients and talking to my prescribers about what's working, I definitely have more information on that. It varies from repurposed drugs like ivermectin and also binders to help bind and denature the spike protein. There's also ways to physically pull it out of the blood, to spin it down, to return the blood that is cleaned back to the patient. Also, chelating agents, high dose antioxidants. So it's not hopeless. We have a lot of things that we can do to help the patient. But if you're in Texas, I think CPL, clinical pathology labs, I think they might only be in Texas. That might not be true, but they definitely are widely located around Texas. There is the order number for the lab for that. LabCorp, again, patients can go on and self-order on LabCorp if they wish. And then Quest, what you're looking for is the total antibody spike. It's a semi-quantitative measurement. So key point here is that impaired spike protein maturation is what we achieve with nitazoxanide, and that equals reduced infectivity of the viral particles. Okay, so what about SIBO? SIBO is something we see more and more of. And again, like when I talked about H. pylori, H. pylori is very tough to treat, as is SIBO. A lot of times we do see treatment refractory situations with small intestinal bacterial overgrowth. Also, we know that there may be some overlap with fungal overgrowth, so that even makes the treatment regimen more fun. Oftentimes, SIBO is a mixed dysbiosis. So, of course, we have our typical desired microbiome, and oftentimes we will get opportunistic infections such as SIBO. Also, candidiasis is one that we treat a lot, and sometimes there is a blend of what's going on there. So, we may see in SIBO a mixed dysbiosis of both gram-positive and gram-negative bacteria, anaerobes with or without protozoa. And usually these symptoms are often driven by anaerobic. Again, remember anaerobic, that P4 is what we are targeting in anaerobic organisms. So driven by anaerobic fermentation, leading to gas, bloating, diarrhea, and constipation. And very tough for folks. Nitazoxanide carries, again, that broader coverage, but broader coverage than rifaximin. Rifaximin is very expensive. We've been approached to compound that in the past. It's not even close to being affordable. Nobody would pay the price that we could compound it at the very least. And also it has activity against, again, those gram-positive and gram-negative bacteria, anaerobes, protozoa, B. hominis, Giardia. So a lot more than rifaximin does alone, but also biofilm-associated organisms. So think the Clostridium, think about C. diff like we talked about before. And then the reason why is because of this P4, so the pyruvate ferredoxin oxidoreductase inhibition. We talked about that before in that it works on viruses and bacteria and parasites and disrupts this anaerobic energy metabolism. So I really hope I'm driving that home for you. It directly impairs fermentation driven gas production, particularly effective in anaerobic environments like the small bowel in SIBO. Now, activity against biofilm-associated organisms is very relevant in recurrent or treatment-resistant SIBO. And that even goes for patients that maybe have used something like rifaximin and they had temporary improvement, but then they relapse. And this can happen too with the hydrogen dominant SIBO. So if they're doing well and they relapse within a few weeks, oftentimes what's happening there is that that patient is carrying around organisms which are smart and they compensate with alternative metabolic pathways. So they're basically redirecting their metabolism so that they can find a way to survive in the body. But nitazoxanide does disrupt these pathways more aggressively and more intentionally. It covers anaerobes involved in the sulfur metabolism and supports combo therapy for even methanogen heavy presentations. Now, clinical benefits, just as far as what's observed, are a marked reduction in bloating, lessened postprandial distension, improved bowel regularity, fewer food intolerances, and reduced nocturnal GI symptoms, and then, of course, enhanced motility. So, as far as the dosing goes in nitazoxanide for SIBO specifically, most commonly, this is what we see more in the functional medicine realm for adults, is 250 milligram capsules. So we make a 250 milligram. I think what's commercially available is a 500. We make a 250 milligram capsule, and we recommend for patients to take 2 capsules by mouth twice daily for 7 to 10 days. They should take that with food to improve absorption, as goes for a lot of the antiparasitic drugs. We know that there's improved absorption when we do take it with food. That goes for ivermectin, mebendazole, nitazoxanide. And then also for the more severe recurrent cases, we'd go for that same dose capsule, taking 2 capsules by mouth, but increasing the frequency to 3 times a day for about 10 days. Now, key point here is that there is a pharmacological distinction when compared to rifaximin. Right, so rifaximin is largely intraluminal and more localized there with minimal systemic absorption, but nitazoxanide is quickly metabolized to the tizoxanide, which gets systemic exposure and absorption and then may reach organisms outside of the lumen that are potentially useful in SIBO if it's overlapping with protozoal or distal small bowel involvement. So it is much more comprehensive in that way. Let's look at some dosing strategies for nitazoxanide across the board. So we talked about SIBO, we talked about flu, we talked about COVID. Again, at physician's preference, we make it in a 250 milligram capsule. Please note that when you're writing prescriptions for nitazoxanide, it does have to indicate on the prescription sugar and dye free. It has to say sugar and dye free. A lot of the nitazoxanide preparations we know contain sucrose and other inactive ingredients that we do not want in there, that our patients do not tolerate. And so our formulation is free of sugar and dye, but you do have to indicate it that way, indicating on the prescription that that is necessary for the patient. Now, remember again, it's indicated for patients greater than 1 year of age. Important to take it with food. And then no adjustments necessary for altered hepatic or renal function. Now, as pharmacists, we are oftentimes using facts and comparisons as our drug database. So that's where we do a lot of screening for interactions and also seek out dosing guidance, but it's for the FDA approved uses. I just put a couple screenshots in here because I want you to see what I'm seeing. If I log into facts and comparisons, I'm going to see a long list of the different uses that nitazoxanide has for peds, for adults, different indications, different dosing, different frequency, all of that. So just to show you here for one of the most common doses, right? We know it's FDA approved for infectious diarrhea caused by Giardia, Cryptosporidium, parvum, etc. So usually what we're looking at is a total of 500 milligrams twice a day, let's say in this case for about 3 days. Of course, we want to get them to resolution. Then if we look at different populations, what I want to point out here is that the duration of treatment, not necessarily the dosage, is usually what changes when we are dealing with an immunocompromised patient or if the indication changes. And so that what that will do is it will change the duration, stretching it out to somewhere around 1 or 2 weeks rather than a few days in many instances. So here, for example, we are looking at pediatrics. And what we see is, for example, we're looking here at Cryptosporidius again, and you'll see that in children aged 1 to 4, and then 4 to 12, and then 12 and older, basically into adolescence, what changes is the dosage, okay, based on the age. And that's pretty much the same across the board. 100, 200, 500, 100, 200, 500. But as the indication changes, if we go from cryptosporidius, just as an example, to fasciola hepatica, honestly, I don't know how to pronounce that, but we have different indications across the board within facts and comparisons. Let's just say you're treating for that specific indication. You can see that the duration changes. So rather than just doing it twice a day for 3 days or something like that, once you have immunocompromised patients or different indications, you will be treating for a longer period of time. Also, there's a note here, treatment duration is 3 days in immunocompetent patients. For immunocompromised patients, let's say HIV, or if the efficacy is uncertain, the suggested treatment is up to 14 days. So you do have some variation there. I have seen prescribers write it between 7 and 14 days, sometimes just a flat 10 days, to be sure that we dispense enough to get their patient through the infection or through the symptoms. Now, as with many repurposed drugs, we love their safety profile because they're tested and true. They've been around for a long time, just for different uses. If you look up the adverse reactions that are present post-market for nitazoxanide, the recurrence or the occurrence, I guess, of these is actually very low. So between 1 and 10% of occurrence, we're looking at headaches, abdominal pain, urinary discoloration, which happens in more than 2% of people, diarrhea, dizziness, rash in less than 1%. So it's very uncommon. Like anything that travels through the stomach, people might have some GI symptoms. Also, the urinary discoloration, sometimes it becomes more of a prominent yellow or even a greenish color. So sometimes that will happen. And then contraindications, nothing glaring. So actually just your standard allergy statement, hypersensitivity or allergy to nitazoxanide or any component of the formulation. So not much to steer clear of there. And the question that we oftentimes get is it safe in pregnancy or breastfeeding, right? What if the woman unfortunately needs to treat during either of those times? Oftentimes the answer is no, we don't have enough information on it. And it's not like there are a lot of studies that have been done in pregnant or breastfeeding women to test nitazoxanide. However, when we consult the Briggs Drugs in Pregnancy and Lactation, which is where we go for pregnancy and lactation direction, actually, although there's no human data in it, it does suggest low risk and in breastfeeding, probably compatible, which means that there is likely very low risk to fetus or if it passes through breast milk to hurting the baby. So that's good. That's actually good news on the safety profile of nitazoxanide. So when shall we consider this for folks? If you have patients that you've been seeing, maybe they're coming to mind right now, or when they walk in your office, they already have a history of treatment refractory SIBO, SIBO with a protozoal overlap, mixed dysbiosis that we oftentimes see in SIBO, a biofilm associated GI infection, poor tolerance or response to rifaximin, very common, repeated prior antibiotic exposure, who doesn't have that? SARS-CoV-2 infection, that's still very much going around, flu still very much going around, especially presently, and then the treatment of parasite-associated diarrhea, which is its FDA-approved indication. So there are, if you go looking on PubMed or wherever you search for your articles and literature, you'll see that there are a ton of studies dating way back, decades back on nitazoxanide. So it's kind of a shocker that we're not talking about it more, we're not using it more, which is why we're here to talk about it, to uncover and unveil the broad range of uses for nitazoxanide. But you'll just see a lot. You'll see that it's a broad spectrum antiviral agent. It's good for H. pylori. We see it in Hep C. We see it in C. diff. We see it in the cryptosporidial diarrhea. Of course, we talked about that. And then also maybe some implication in ulcerative colitis. Now, here is just a snapshot also that I pulled from clinicaltrials.gov, which gives us information about studies that are recruiting. So there is evidence, a long list of evidence on PubMed or wherever you find your literature, but also there's still ongoing studies. Nitazoxanide in patients with metastatic colorectal cancer. That's a big one right now. Novel regimens in COVID-19. So there is a lot of ongoing information that's being studied, H. pylori, ulcerative colitis again. So we'll stay tuned on that, especially as new information continues to emerge. So I want to thank you so much for tuning in with me today. Of course, I will address any questions that we may have, but please go ahead and be sure that you jot down my email address here, also the phone number directly for the pharmacy. If you have any questions about specific patients or people that have come to mind and you're wondering about the dosing strategy, maybe they're on some of the other repurposed drugs as well, and you want to know how to fit it all together, that's why I'm here to help answer those questions for you. Of course, you can reach out to us and speak with any of our pharmacists, or you're more than welcome to reach out to me directly if you wish. And certainly it would be our privilege to serve you and to partner with you. So I'm going to go ahead and stop sharing my screen now and see if we have any questions that have popped up here. You're more than welcome to put them in Q&A, or you can put them in the chat. So I do have a couple here. It says, glad to hear you talk about COVID. I am running these on pretty much everyone. So I'm guessing that, yeah, she's talking about spike proteins, such a jump in autoimmune symptoms. Yes, for sure. So on the spike protein quantitative, we can't differentiate between vaccine and infection, correct? That is correct. So when you draw a spike protein total antibody load, that semi-quantitative total load, it's not going to tell you if the patient has spike that originally came from the infection through natural immunity or if it came via vaccination. And I'm sure you're seeing the same thing, whether or not you're recognizing it, I suppose. But when we used to have patients maybe 3 or 4 years ago that were vaccinated, in general, they had a much, much higher spike load. But something that has been just pretty tough to hear about is the neuropathy and the seizures that have come post vaccination. And we've helped a lot of people bring that spike protein down. Some of it involves our pharmaceutical agents, our compounds, and some does not. Honestly, if I were to recommend a whole regimen, or talk about a whole regimen with a prescriber or a patient, maybe 10 or 20% of what we're doing actually comes from the pharmacy. The rest is a really great way, if you're not already doing this, to incorporate intravenous therapy for chelation and high dose antioxidants, et cetera, in your office. Run these IVs. Also, other options like EBU, for example, some people have success pulling that out. It's my understanding that the spike protein that settles in those EBU treatments is pretty staggering and pretty obvious as far as what it looks like. So you can immediately bring that down. Again, supplements are another option as well. But some of the neuropathy and the seizures and these odd symptoms that have come up, specifically post vaccination, are a big deal. Even with the tests that are available, my understanding is the technology is still not maxed out enough, I guess you could say, where we could even get someone that's popping off the chart. So I think there's a max of like number of 20,000 or something like that, which a lot of vaccinated individuals do show up at. It's very unlikely for a non-vaccinated individual to show up that high. It seems like usually the natural immunity people are in the few thousands. The vaccinated are 8, 10, 12, 20,000. And that's a much bigger deal because they have much more spike. The spike likes the reproductive organs, it loves the brain, it loves the central nervous system, it loves to take advantage of and hijack the immune system. So help your patients get that out. I do tell patients and prescribers that we want to shoot for a 20% reduction in spike protein antibodies every 6 months. If a patient is able to stay adherent with and they tolerate the treatment regimen on a daily basis for 6 months or so, we expect them to, and I've seen patients bring it down on the nose, 20% that spike protein level every 6 months. So it's not that expensive. I think it's about $50 cash pay to run this spike protein test. So that's not that much to pay about $100 a year to have it tested every 6 months. I personally get mine tested every 6 months because I am also exposed to patients, of course. And as far as my best understanding is, we like to keep that number, that spike protein number, generally under 1,000, because we are going to go to the grocery store and probably get shed on. We are going to see patients and probably get shed on. We are going to get COVID, and then we're going to have a higher spike protein load. Additionally, something we're not talking about that much, spike proteins are sexually transmitted. And one of the most potent vectors of that is male ejaculation. So if you have, specifically, one of the toughest situations is you have a husband and a wife, where the male is vaccinated and has a high spike protein level and won't do anything about it, won't treat. The wife is more on the functional side. She would come to see you, she would use our pharmacy, she would do what she can to bring the spike protein down, but she's going to keep getting shed on through semen. So that's a really tough one. That's a sit down conversation with the couple, and you just navigate it as you can. Another question about application for HSV1 or 2 or shingles. So that's not something I came across in my research. I definitely can see the extrapolation of how that might work. I am going to look more into that for sure. I'll get back to you if I can see if I can find something on that, but that makes a lot of sense to me as well, especially with the immunocompromised individuals. And then another comment here, would love to see a webinar on methods to lower spike protein. So that was a follow-up to an initial comment she made. So hopefully I provided some clarity too on how to lower those spike proteins, but that probably does warrant a further conversation. But also, if you have more questions about that, we can talk about that as well. All right, let's see if we've got anything else. Okay, well, if we don't have any further questions, please give me a call, write me an email. You can expect to see a replay with the resources as well as a copy of this PowerPoint in your email soon. So thank you again for tuning in, and we will see you here in the next month or so for our next topic. All right, you guys take care. Talk to you later. Bye-bye.